I'm going to be speaking about caustic ingestions. I don't have any conflicts of interest to disclose. One disclaimer, my lecture is based upon my practice in the United States. We may have a different practice pattern here. We may have slightly different resources. So, depending upon where you are, the toxins you're going to be encountering, the resources that you have, and kind of the treatment modalities, and also practice patterns may just vary. It's really wonderful over the last few months to get to work with you all remotely. And I would love to hear from all of you during the lecture and afterwards too, just about your practice patterns in Nepal, what caustic exposures you commonly encounter, because I think it's really fun to learn from you all, and I feel like I've learned a huge amount already. For the talk, I will be focusing first on just the three major dangers which I think about when we have a caustic exposure, specifically the upper airway, and then to a lesser extent, the lower airway, the GI tract itself. And then I also do think about systemic toxicities of certain agents. I will focus too on the workup and treatment of GI tract injuries specifically, since that really does oftentimes become the primary concern um, in caustic exposures. I'll talk briefly about button batteries as well. That's a very specific caustic exposure, which I think deserves a quick mention. Briefly touch on dermal and ophthalmic decontamination procedures. And then finally, at the end, if we have a little time, I'll go through a quick case, which I think kind of hits all the different concerns that I have about airway injury, GI tract injury, and then systemic toxicity. So I think it's important first to define what a quote unquote caustic is. And if you look at Merriam-Webster's dictionary, it describes it as a substance that's capable of destroying or eating away by chemical action, something that's corrosive. And we're usually referring to acidic and alkaline substances when we talk about caustic ingestions. But there are also some other agents which aren't particularly alkaline or acidic, which may have alkylating properties, oxidizing properties. They may be reducing agents. They may denature. They may defat tissues, and they can exert caustic effects through those mechanisms. And then also, we'll talk about button batteries too. This series of photos, I think, highlights the three major concerns that I have with caustic ingestions. On the upper left here, you have a very swollen tongue, which you can see is clearly compromising this person's airway. Caustic agents can cause, before they even reach the GI tract, really, really horrible injuries to the upper airway, which can quite acutely be dangerous, but then you can also have delayed swelling as well, which may not manifest initially, but hours later on, you can have a very swollen tongue or a very swollen oral pharynx or epiglottis. And I think this picture really symbolizes that. In the middle photo, you can see various degrees of esophageal injury, which are getting progressively more severe as we kind of move along, progressing to kind of widespread necrosis. So that's a big concern when people are ingesting caustic or corrosive agents. And then again, certain agents, for example, paraquat or diquat or hydrofluoric acid will have systemic toxicities, which you need to have in the back of your mind too. So I apologize for the somewhat gruesome photos. You can see here you have someone's tongue, the oropharynx, uvula, and you can see how there are just kind of these really hemorrhagic, nasty looking erosions caused by caustic injury. And then you see this poor child here who has ingested some sort of caustic agent, has some burns around the mouth, and then presumably had a very swollen tongue, so actually needed to be intubated nasally. And then we have a photo here, and you can see, oops, you can see right here the epiglottis itself, which is quite swollen, has some erosions. Then you have your vocal cords through here, and then the area posterior to the vocal cords as well. But when you're thinking about the airway, I tend to sort these patients into three groups. There are people who come in who are clearly in extremis. They have a swollen tongue, they're drooling, they're hypoxic. There's that subgroup, it'll be very obvious that that group needs immediate airway protection. They need to be intubated right away. And hopefully you're able to intubate them through the oropharynx. You might have to intubate them nasally. You might even have to do a cricothyrotomy. But I think that group is fairly easy to pick out. There's a third group as well, which they are clearly not an extremist. They're doing very well when you see them. They might be sitting in their stretcher, texting on their phone, sipping on a soft drink. They don't have any lesions in the back of their throat, so you have zero suspicion that they acutely need airway protection. And then also, you have very little suspicion that down the road they are going to gradually progress to develop airway edema and need an intubation down the road. So I think that group you can pick out as well using your clinical gestalt. I think the trickiest group is the group in the middle. So they're not obviously the intubate now group, and they're not obviously the they will be okay now and they will be okay later group. But group two, you think they're probably okay now. They might come in, they might be complaining of a little bit of a sore throat after a caustic ingestion. Their voice might be a little hoarse. Maybe they have a little bit of a burn in the back of their throat, but they're not an extremis. Now, that group, although they look okay right in the moment, may actually progress to developing very significant airway edema a few hours later, perhaps a day later. And they might also need to be intubated for an EGD. So that might be a group that you prophylactically intubate ahead of time before they develop a very difficult airway. And I would argue if you have a patient in that group, you're not quite sure whether or not they need to be intubated, nasolaryngoscopy can actually be your friend. And that can actually allow you to visualize the epiglottis, the vocal cords, the posterior oropharynx, and kind of risk stratify and figure out whether or not they may need to be intubated ahead of time before they develop airway compromise. Here's just a diagram on the left just showing fiber optic nasolaryngoscopy, where you're putting that scope down through the nose, looking at the epiglottis, the posterior oropharynx, and the vocal cords. You can see here someone doing this in the office, but we do this in the emergency department or in the hospital too. And if I were to do that in a patient I thought might need airway protection, but I wasn't sure, and I were to see, for example, this very swollen epiglottis, that would push me towards intubating them immediately rather than waiting. Likewise, if I saw very swollen vocal cords, I might think about that as well. And it's worth keeping in mind, usually we're thinking about injury to the upper airway, but sometimes patients can aspirate and they can actually have injury to the tracheobronchial tree as well. Here's a CT scan of someone who developed pretty significant pneumonitis after an acid ingestion. I think this is from about a month or two later, but they have done follow-up bronchoscopy, and you'll see there are actually still these very significant injuries to the right mainstem bronchus. So you can develop injury not just to the upper airway, but to the lower airway as well. So that covers the airway, but let's talk now a little bit about the GI tract itself. We'll go through a few different principles. We tend to think about very acidic or very basic substances being particularly concerning. And when I say really acidic, I'm talking about a pH usually less than 2, or when I say really basic, I'm talking about a pH greater than 12. These are not absolute numbers, and there are certainly substances which, as I mentioned before, may not be very acidic or basic, but because of their chemical properties can still be quite caustic, but we get more concerned if they are really acidic or really basic. Now, acids tend to cause what is called coagulant necrosis. They cause more superficial injury, but the acid is not going to penetrate more deeply. On the flip side, alkaline ingestion, so for example, bleach or lye, is going to cause what's called liquefactive necrosis. And this is not only going to injure the superficial tissues that it first comes into contact with, but it's going to penetrate more deeply as well, which is quite concerning because you injure, let's say, not only the esophagus, but you might kind of penetrate all the way through to the mediastinum. Or about industrial or concentrated strength solutions. Household solutions of bleach, for instance, or some other cleaning product, which are fairly dilute already, have a lower potential for causing injury. And this is also not an absolute rule, but usually percentages of 5% or less of the active corrosive or caustic ingredient are more reassuring. We do not neutralize acids or bases. And by that I mean, if someone were to ingest an acid, I would not then administer a base to neutralize that acid and to create a neutral pH. And if you were to attempt to neutralize an acid or a base, you might normalize the pH, but you can actually create an exothermic chemical reaction, which can be quite injurious. We, in general, as well, do not use nasogastric or orogastric tubes to decontaminate the GI tract. So if someone presents soon after a caustic ingestion, I would be very hesitant to blindly place an NG tube to try and suck whatever whatever caustic agent was ingested out of their GI tract. There's a good chance that a lot of it will have already kind of penetrated into the tissues. And additionally, if you have significant caustic injury to the GI tract, those tissues of the esophagus and the stomach are going to be pretty fragile, and blindly placing a nasopharyngeal tube in there can be quite injurious and could potentially cause a full thickness injury. Likewise, we don't tend to give charcoal either. Charcoal can definitely adsorb to a lot of substances and prevent systemic absorption, but caustics, they tend to be absorbed pretty quickly. And additionally, if you are going to do endoscopy to visualize the extent of the GI tract injury, you are going to have this black tarry substance, the charcoal, obscuring the endoscopist's view, so they can't really grade the degree of injury. Likewise, if you were to develop a full thickness injury and you ended up perforating into the mediastinum or into the peritoneum, it can make things very difficult for your general surgeon if they are just seeing a bunch of charcoal in their surgical field. Now, I will say there are a couple of exceptions to this. If we think this is a very, very dangerous, lethal ingestion if you don't do anything, for example, paraquat, which is an herbicide that is quite corrosive, and then also causes horrible pulmonary fibrosis and death if you ingest even a relatively small amount. That might be someone I would say, okay, I will make an exception to the NG tube placement rule, and I might give charcoal as well, just because we're going to try and do anything possible to try and decontaminate the GI tract. But in general, no charcoal, no NG tubes. It can also be good if you're not quite sure what was in the product that was ingested. You can look up the safety data sheets for a lot of these products. What I will typically do is just use Google or whatever your search engine of choice is. I'll type in the product name, and then I'll type in MSDS or SDS, which is Material Safety Data Sheet or Safety Data Sheet. And you can't always find a safety data sheet, but oftentimes, as you see with the example of Drano here, you are able to get a sense of what the chemical properties of the caustic agent are. So if we Google Drano, which is commonly used for kind of cleaning out toilets and sinks here in the US, you will get a pH range, and you can see the range is up to 13.4, so that's potentially concerning, right? That's greater than 12. And then you'll see there's both sodium hypochlorite and sodium hydroxide, so bleach and lye. And percentages of each of these are up to 5%. So that's a total of 10% of a pretty concerning pair of alkaline substances. So when I see this material safety data sheet and I hear that a patient ingested a bunch of Drano, I find that concerning. And historically, we know that Drano ingestions can have pretty significant GI tract injury. So acutely, what we are most worried about is perforation. And you see here, this is from autopsy, so the patient unfortunately didn't survive. But this is a patient who ingested sulfuric acid. And you'll see that, maybe a little bit of injury to the esophagus, but the stomach has essentially been liquefied and perforated. So you worry about with caustic ingestions, injury to the esophagus, injury to the stomach, and then sometimes you can even have injury to the duodenum. Acids in general tend to be less injurious to the esophagus and more injurious to the stomach, and the opposite is true for alkaline substances. There's a saying we have that acids lick the esophagus and bite the stomach. So in addition to potentially having severe injury to the esophagus or the stomach, necrosis, sometimes even full thickness perforation, which can result in mediastinitis or peritonitis, you may also just have GI bleeding that results. And then chronically, and actually I'll just point out here, so this is a chest x-ray from someone with a caustic ingestion, and you can see here they have right-sided pleural effusion, which if I saw that in a patient with caustic ingestion, I would find very concerning, because that suggests that you have some sort of caustic agent which has managed to make its way out of the GI tract. And chronically, the thing we worry most about are strictures. And these are usually strictures of the esophagus, sometimes of areas of the stomach as well. But these can be really, really debilitating. If you survive the acute ingestion, it's really horrible if you then go on to develop a severe esophageal stricture. which gives you years of difficulty eating, drinking, pain with swallowing. This is a barium swallow, and you can see here, here's the esophagus, and it gets a little dilated right before this very narrow stricture. And imagine trying to get your daily oral intake down through that stricture into the stomach. So really disabling. And these will oftentimes be treated with dilatation, either with a bougie or with a balloon. You can see these photos here under fluoroscopy of balloon dilatation, an esophageal stricture. Here's a picture pre-dilatation, and this is during the dilation procedure. The problem with this is these strictures are oftentimes refractory to repeated dilations, so people might get dilated every other week for up to 12 weeks, but oftentimes, despite dilating and maybe injecting steroids or other agents, they will just continue to recur. And these people will need very invasive surgeries. There are two procedures. One's called a gastric pull-up, which you can see in a fluoroscopy here, where you've essentially resected the injured area of esophagus and then pulled the stomach up into the mediastinum and connected to the residual esophagus. Another one that will sometimes be done is colonic interposition, where you're taking a piece of the colon and using it to reconstruct the esophagus. So really invasive surgeries with high morbidity. So you do not want to end up with refractory strictures. Patients can sometimes develop fistulas either between the esophagus and the tracheobronchial tree or between the esophagus and the aorta, which is obviously very dangerous. And then people who have caustic ingestions are at increased long-term risk of developing esophageal cancer. I would also emphasize, again, strictures are very debilitating and painful long-term. So you imagine someone who has just ingested some sort of caustic agent, and putting aside patients who made a mistake and it was an exploratory ingestion, it was not intentional. There are a lot of people who are ingesting this for self-harm reasons. So if you are already dealing with significant depression that brings you to the point of having a suicide attempt, imagine that you survive that and then you face years of painful swallowing, difficulty eating. So you are further burdening someone's already poor mental health with a stricture, which is really bad. And we want to do everything we can to prevent these strictures, because that then places patients with depression and other mental health disease at increased risk long term. So this brings us to the question of how do we assess GI injury severity, and can we alter the course of injury? Can we decrease the risk of these really debilitating strictures? So I'll talk first about endoscopy, which is our traditional method of assessing for GI tract injury. We've done this for a number of years, and there is a commonly accepted grading scale called the Zargar grading system. This was developed by Dr. Ali Zargar, who is from India, in the early 1990s. And you'll see here, we have grade 1 lesions. These are the least severe, and there's just some edema and erythema of the esophagus. Zargar 2A lesions are when you have some superficial scattered ulcerations and maybe some hemorrhage too. Then when you get to Zargar 2B, this is the beginning of the more severe series of lesions. These tend to be deeper focal ulcerations, and they're oftentimes circumferential. When you get to the 3A category, now you're developing focal necrosis, and then 3B, you're developing extensive necrosis, which is really bad. And then grade 4 is perforation. Now, grade 2B, 3A, and 3B are high risk of developing strictures. 2B lesions, anywhere from 30 to 70% of the time, you'll go on to develop strictures, and it's close to 100% stricture risk if you end up having actually focal or extensive necrosis. And these three groups are also at increased risk of developing malignancies long term. So if they survive, they will then need endoscopy periodically in the ensuing years to make sure they're not developing esophageal cancer. Now, we're trying to do endoscopy within the first 48 hours. Usually, you want to wait perhaps 6 hours or so that the lesions can fully mature and you're able to assess how severe they are. But you don't want to do endoscopy beyond 48 hours because you end up being at increased risk of causing perforation. Beyond that point, we think that the esophagus, when it's injured, becomes more fragile. And if you're injecting a bunch of air, insufflating, during endoscopy or just looking around with an endoscope, you could potentially cause a perforation. And then typically, usually you don't, beyond 48 hours, you don't do endoscopy again until you're probably about a couple of weeks out. Now, as I said before, strictures are very debilitating. So there's been a lot of thought about whether we could do something to mitigate risk of developing strictures long term. There have been a few different trials which have used steroids, and the thought here is that by giving high-dose steroids for some period of time, that you might inhibit fibroblast proliferation, and fibroblasts are one of the cell types that are involved in kind of healing and recovery of the esophagus after a caustic ingestion. And fibroblasts tend to be particularly active about 3 weeks after your caustic exposure. So certain research groups have given high-dose steroids, sometimes for just a few days, sometimes for multiple weeks, and looked at whether that decreased your stricture risk. Most of the studies have not shown a benefit, and some have suggested harm, but these have looked at a wide degree, a wide variation in severity of esophageal injury. There was one particular study, though, by a group headed by Dr. Usa in 2014, which looked specifically at 2B lesions. So those circumferential lesions, which are pretty deep, but there's no necrosis. And in 83 children with 2B lesions alone, they found that high-dose methylprednisolone, so 1 gram per 1.73 meters squared, given for 3 days, actually markedly decreased the stricture risk. And stricture risk actually went from about 45% to 14%. So you have decreased your stricture risk by 2/3 by giving steroids for 3 days. And it's a fairly short course, so your risk of complications like hyperglycemia are pretty low, and you're not giving it to higher grade injuries with necrosis. So likely your risk of increasing the risk of perforation is fairly small too. So a lot of U.S. toxicologists, and I would emphasize not everyone, but a lot of U.S. toxicologists will recommend doing endoscopy in large part to find patients with these 2B lesions, which may be amenable to steroid therapy. Now, I personally think the risk of kind of caustic injury, or I think the long-term morbidity of strictures is so high that I think it's very much worth doing EGD to identify patients who may benefit from steroids. And I feel comfortable applying this pediatric data to adults as well, but that is by no means universal. But that is my personal belief. So, what about an alternative to endoscopy? CT has emerged as an alternative to endoscopy, and this is typically done with IV contrast alone. You don't need to give oral contrast. And at least in the United States, CT tends to be more accessible in smaller hospitals and also during off hours, so overnight. And it's really nice because it can rapidly tell you whether or not you have a full thickness injury, whether whether or not you have a perforation. And this is really useful. And endoscopy may have a higher number of false positives pointing you towards surgery. And by that I mean you may do endoscopy and you may see some necrotic lesions and stage an esophageal injury as 3A or 3B. And if you do that alone, you may be more likely to take the patient to surgery. But if you were to CT them as well, you may actually realize that they don't have a truly full thickness injury. So, in addition to just kind of higher degree of accessibility, CT also has fewer false positives than EGD. You do need to have a good radiologist who's very comfortable looking at the esophagus. And if you look at these images, so in the lower part here, you'll see this thin white line right there, which I've kind of pointed out with the red arrow, and over here as well. And that is your post-contrast enhancement. So you've given venous phase contrast, and you're getting enhancement of the stomach lining and enhancement of the esophageal wall. So if you see that, you know that you don't have full thickness necrosis. Now, on the flip side, up here, it's kind of hard to see, but here's the esophagus right here, and here's the stomach, and you do not have any post-contrast enhancement, which tells you that there is full thickness necrosis. And if you look here, you see some air bubbles as well, which is concerning too. Now, it's important to note CT does not give you Zargar grading. So you're not able to find, based on CT alone, those Zargar 2B lesions and make a decision whether or not to give steroids. Let's see, I'm just going to look at the chat. Uh, just quickly looking at the chat too. So how long does it take a stricture to occur? That's a great question. It can be as soon as 3 weeks out. In some people, it manifests later, more than 8 to 10 weeks out, but I don't have an absolute number. And I also defer to any gastroenterologists on the call. But yeah, 3 to 10 weeks, somewhere in that range seems quite reasonable. So incorporating both CT and EGD, I had this proposed algorithm, and a lot of U.S. poison centers probably practice somewhat similar to this, but there's variation, and this is also predicated on there being availability of both CT and EGD. So I think the first thing you want to do is look at the airway. Is your airway protected? Does the patient need to be intubated right away? So once you have determined whether or not you need to protect the airway, then you want to think about, are they stable or not? And if you're not stable, and by that I mean they're hypotensive, they have peritonitis, um, they are clearly in extremis. A patient like that, I am actually just going to call surgery right away, because someone like that is not going to be an appropriate candidate for endoscopy. They may not even be stable for CT. That may be someone who just needs to go to the OR right away, and they are going to have a very high mortality if you have esophageal or gastric perforation. If they are somewhat stable enough, getting that CT with IV contrast can be very helpful to get additional data. On the flip side, if they are stable, I think the next thing you want to ask yourself, was this an intentional ingestion or not? And that's a help give you an idea of how much they likely ingested. Someone who accidentally takes a sip of an unlabeled bottle and then realizes it is a caustic agent is going to probably spit a lot of it out and won't swallow more than a sip or so. Likewise, young children who may have an exploratory ingestion but weren't intentionally trying to ingest a large volume, they are just, I'm not saying they can't get sick, but they are at lower risk of ingesting a lot of a caustic agent and having severe injury. So if it's not an intentional ingestion, then you want to think about, are they asymptomatic? Are they tolerating oral intake without difficulty? A patient like that can probably be observed for a period of time. And if they do okay with their oral challenge and are asymptomatic, they can go home. If they have vomiting, or they have drooling, or they can't tolerate PO, that's someone who I would keep NPO overnight, so nothing by mouth, and then I would see if they are able to eat and drink in the morning. And if they are, great, they can probably go home. But if they don't, if they're not able to tolerate oral intake, that's someone I would then think about doing EGD in or endoscopy. Now, if they have an unintentional ingestion, but they come in and they have vomiting and drooling, or they have stridor, which really suggests there's some upper airway compromise, someone like that, I do want to get endoscopy in them if endoscopy is available. And then likewise, if is an intentional ingestion, by and large, that is someone I would definitely think about endoscopy in, unless it was a 48 hours. If you have those lower grade lesions, 0, 1, or 2A, so not circumferential, not super deep ulcerations, those are patients who you can really just advance diet as tolerated. If they end up having 2B lesions, so those deep circumferential ulcerations, those patients are going to get 3 days of high dose methylprednisolone, and we usually give them antibiotics and a proton pump inhibitor like pantoprazole as well. If I see 3A or 3B lesions, so there's some degree of necrosis, those are people who I would definitely get a CT scan in, and I would speak with surgery as well. And likely, it is going to take a lot longer to advance their diet. Now, this is an algorithm which we use in Northern New England. It is somewhat complicated, as you can see. I usually have to look at it and think it over in my head for each patient. And I will usually involve gastroenterology and our surgeons too, if appropriate, because they are very intimately involved in managing these patients. Um, Again, there is a lot of regional and international variation in practice patterns, and there's also variability in access to EGD and also CT scan. If you don't have access to EGD or endoscopy, but you do have CT, CT can be very useful to at least rule out a full thickness injury. So what about a stable patient, but you don't have any access to endoscopy or to CT scan? If there's a concerning history, they ingested a very dangerous substance, they ingested a very large volume of it, it was a suicide attempt, those are patients I am more concerned about. If they have an abnormal exam, they have oral lesions in the back of their throat, burns. If they have dysphonia, a change in voice, if they're having painful swallowing or they're repeatedly vomiting, that's concerning. If I look at their labs, they're very acidotic, which could suggest significant absorption of acid or maybe perforation. They have a very elevated lactate. If they have a very elevated white blood cell count, those are all concerning things. In a patient like that, if possible, I would try to transfer to a place that is able to do endoscopy, both to assess for degree of injury. You could always place an NG tube via endoscopy. To help with feeding, and again, you're doing it under endoscopy, so your risk of perforation is going to be lower than if you're placing it blindly. And then it also allows you to find patients who may be appropriate for 3 days of high-dose steroid therapy. But if you can't transfer someone for endoscopy and you don't have CT, I think I would admit a patient like that for monitoring and would gradually advance their diet. And I don't have a precise time over which I would advance their diet, but I think you want to make sure they're tolerating their saliva first. Then you would gradually advance to liquids, then to a soft diet, and then just progress to usual foods. And then you want to make sure that they have follow-up as an outpatient because at 1 to 2 months down the road, they may develop a stricture, they may need dilations of that, and they also need surveillance periodically to make sure they're not 10 or 20 years down the road developing esophageal cancer. Systemic toxicity, I mentioned before, you can definitely see acidosis and alkalemia from systemic absorption of caustic substances. And then you don't have to memorize these, but it's worth remembering that some substances which are caustic are going to have specific non-corrosive toxicities. So, for example, hydrofluoric acid may cause hypocalcemia, it may cause hyperkalemia. Diquat, which is a very effective, cheap herbicide, may cause renal injury. Paraquat, another very effective, cheap herbicide, which I talked about before, can cause horrible pulmonary fibrosis. And that's one where if you ingest even really a cupful, I think the average lethal amount is about 14 cc's or milliliters of 20% concentration. So even a small amount of paraquat can be horribly lethal and can kind of condemn you to either a fast or a very slow, painful death. So in someone like that, I'm keeping that systemic toxicity in the back of my mind, and I am thinking about maybe doing an NG tube and giving charcoal, despite us not normally doing that for most caustic ingestions. But I would just look up whatever substance the patient was exposed to and think about what specific systemic toxicity they might experience. Quick note about skin and eye decontamination. Don't forget, if someone is ingesting a caustic, they may splash some in their eyes, they may splash some on their skin. So you want to get any potentially contaminated clothes off. If they have contact lenses, you want to get those out immediately. You really want to copiously irrigate with water whatever part of the body was coated in the caustic. If it's the eye, you want to keep irrigating until the pH of the eye is normalized. And then you want to do a fluorescein stain afterwards to see if there's any corneal burn, ulceration, abrasion. And then if you need to, you can always speak with an ophthalmologist or a surgeon. Button batteries are a very specific caustic agent. You'll see them here. They're quite small. And there are a number of different sizes, but these can cause caustic injury very rapidly. And the concern is usually that they get lodged in the esophagus and they have both an electrical current that they generate, and then sometimes the contents themselves can be caustic and can leak out. If they are lodged in the esophagus, this is a four-alarm fire. These can perforate the esophagus within a matter of hours. And if you want kind of a demonstration of this, you can look up videos of button batteries being put inside a hot dog. And you will see they just rapidly burn through the hot dog, which is a good proxy for the esophageal tissue itself. So while you're trying to get them to endoscopy to extract the button battery, You can give them honey if they're greater than 1 year old, and that's going to form a physical barrier between the button battery and the esophagus. You could also do sucralfate as an alternative. People have talked about also using jelly or jam too, but you're trying to get some physical barrier between the button battery and the esophagus while you get it out. And these can form fistulas either with the aorta, with the tracheobronchial tree. They can be very, very bad. Other batteries besides button batteries, we don't worry so much about them actually being caustic. We worry more if they are larger batteries about them potentially posing a mechanical obstruction risk. But usually, if they're less than about 5 centimeters in length by 2 centimeters in size, usually they'll get by um, the pylorus of the stomach, and they'll be able to pass into the small and large intestines and be passed over a period of days. So the last thing I'll talk about briefly, just to drive home the different points I was talking about, the risk of airway injury, GI tract injury, and then systemic toxicity. This is the case I had a couple years ago in Boston. A 33-year-old man presented to a large academic hospital ED, so a pretty well-resourced emergency department, several hours after ingesting a product called Roundup Concentrate Plus. And we looked at the material safety data sheet, and we realized that this had 18% glyphosate, which is both an herbicide and it's known to be nephrotoxic. And then there was also 0.73% dicot, which is a known nephrotoxin as well. The pH itself was not very concerning. It was only 4.6, so not particularly acidic, but we do have a fair amount of data suggesting that both these agents are fairly caustic. Now, this was an intentional ingestion, so he drank a fairly large amount because he was trying to kill himself. So 6 gulps worth, and I don't have an exact volume in milliliters, but that's a large amount. So it places him at increased risk for toxicity. And he had immediate onset of throat pain, nausea, and non-bloody vomiting. For his physical exam, his vital signs were fairly normal other than mild tachycardia. But when I saw him at the bedside, he looked pretty well. He was a little uncomfortable, but he by no means looked toxic. He was not an extremis. When we looked in the back of his throat, he had a little bit of erythema there, and his voice was a tiny bit hoarse, but he was able to speak to me in full sentences. He didn't have any stridor, he didn't have any drooling. So I was not concerned for impending airway obstruction or compromise. And his creatinine was mildly elevated, 1.6 mg per deciliter, or if you're, hopefully I did the conversion right, but if you, it would be 141 micromoles per liter. And his other labs were normal. So I did not recommend nasolaryngoscopy or intubation, and in retrospect, I wish I had recommended nasolaryngoscopy. I did not recommend a CT scan or a surgical consult, but I did recommend that the patient be seen by the gastroenterology team for endoscopy, and he did get put in the intensive care unit for close monitoring. On his first hospital day, his creatinine increased precipitously up from 1 to 5.3 mg per deciliter, so up to 469 micromoles per liter. This was within 24 hours, and he then became anuric as well, so no urine production whatsoever, which is an expected systemic toxicity of dicot and glyphosate. A hemodialysis catheter was placed, and hemodialysis was performed for supportive care and removal of residual glyphosate and dicot in case any was still present in the bloodstream to be dialyzed. He ended up being intubated for EGD within 48 hours of his ingestion, and we're running short on time, so I won't read this whole intubation note, but I'll make the point that there were 3 attending anesthesiologists because this is a large academic hospital, and it required the 3 of them 7 intubation attempts in total using multiple different modalities. And it was a very deformed, very difficult airway. So reading this intubation note, I wish I had recommended nasolaryngoscopy the previous day, and potentially, based on those findings, we would have made a different decision about when he was intubated. But he was eventually successfully intubated. EGD did show Zargar 2B lesions with circumferential ulceration. There was no necrosis. He received methylprednisolone 1 gram daily for 3 days, and he was subsequently extubated. His renal function almost completely normalized. Dialysis was discontinued. And then at outpatient follow-up a couple of months later, He has no esophageal strictures, no dysphagia, and his depression was well controlled with a selective serotonin reuptake inhibitor, and he has good follow-up with psychiatrist and therapist. So this was a happy ending to what could have been just a really horrible poisoning with some long-term disability, but he actually came through pretty well, which was good. So that's all I have. Thank you all very much for letting me talk. I'd love to take any questions, and then if you had any thoughts about kind of differences in how you practice, any caustic exposures you particularly tend to see, I'd love to hear them. I would note this is a great review article, actually written in part by one of my former fellowship director, ingestion of caustic substances. It's a great overview of the management of caustic ingestions. And thank you to all of you for all the spies at the Nepal Poison Information Center for teaching me too through all the exposures that you've had and talked to me about.
Thank you so much, Jim. That was fantastic. Really great overview. Maybe we'll take one or two questions because we're running low on time. But what we'll do is you guys can write the questions and we'll follow up with Dr. Jim and compile the answers and get them back to you if there are many questions. So maybe one or two questions. So we have one question here, Jim. Do we perform EGD within 24 hours or 48 hours?
I think you're within 48, your risk of perforation is going to be even lower within 24, but most people would say within 48 is acceptable. But once you pass beyond 48, then it starts to get a little riskier. I know there are some people who will do it even later, up to 96, and actually, I think in that Zargar et al. Paper, which kind of was the standard for grading esophageal injuries, they were doing it up to 96 hours. But I think in general now we say within 48 hours is best.
Perfect. Thank you. Any other question? One more question, and then we'll move on to our next talk. Jim, one of the common things that we get calls at the Poison Center is, to put a NG tube or not, to do a gastric lavage or not, which, it seems pretty clear from your talk, NG tubes and no.
Yeah.
And gastric lavage probably is a no as well. But
Yeah.
if you could chime in on that.
So that's a great question. And again, I acknowledge practice patterns vary in different areas of different countries, different areas of the world. We in general in the United States, I think the American Academy of Clinical Toxicology, which kind of covers a little bit Europe and Canada too, have moved away from doing gastric lavage just because in general, the risks associated with it, perforation of the esophagus, pneumonia, aspiration pneumonia, they're pretty high. And so we kind of said in general that the risks outweigh the benefits. It's also technically challenging. You have this, if you're doing it, you're usually doing it with a very large tube, like a 36 French Ewald tube, which a lot of places won't have. And even depends on the substance, but if it's a pill, even that big tube, it's actually still hard to suck out, a lot of pills. So I think in very select cases, let's say if you don't do everything you can to minimize absorption, this patient is going to die. So like colchicine or paraquat, things like that, on a very select basis, I would consider doing it. But I do not think it should be in my opinion, a kind of widespread gastric decontamination measure. And likewise, we don't tend to induce vomiting with Ipecac anymore. The two big things I think are charcoal, pretty widely acceptable as long as the patient is not at risk for aspiration, because that can cause a bad pneumonitis. And then like large ingestions of delayed release medications, we think about whole bowel irrigation. But those are really the two GI decontamination things we still do.
Okay. Thank you so much, Jim. Yeah, virtual round of applause for you. And if you stay on, maybe we'll have questions at the end as well.
Thank you
So,
all.
so I want to remind everyone, we have some really exciting news, is that you're all going to get CPD points for this lecture and lectures that we have at the Poison Center from now on. So But you do have to stay till the end, and the sign up form is going to be at the end. So please stay for that before you go. Now we're going to move on to our next talk, and it's from our very own Dr. Pravin Prasad. He is an assistant professor in the clinical pharmacology department at TUTH. He's been really instrumental in getting this poison center started, and kind of supporting from a national team. He's always been available and there for us. So we really thank him, and he's going to be talking about plant toxicology in Nepal and its management for the next 15 minutes or so. So please welcome Dr. Pravin Prasad. You're on mute. You're on mute.
Okay, I think I'm audible now.
Yes.
So sorry. So just a quick review. So greetings everybody. I'm Dr. Pravin Prasad. My primary affiliation, as Dr. Ramu has said, I'm assistant professor at Department of Clinical Pharmacology, Mars Middle Campus. And today I'll be talking about the plant toxicity in Nepal and its management. So just a brief background. Uh, the Nepal, our country, it's a land of huge geographical variations. We have lands as low as 60 meters from the sea level and as high as the height of the Sagarmatha. And if we talk about the medicinal use of plants in Nepal, it was in 1969 that we had a publication from the Royal Academy. It was the Nepali Nighantu. It contains it has compiled the traditional knowledge of 750 plant species of Nepal. Recently, in 2008, we have another publication that has reflected the ethnomedical importance of 554 plants from Nepal. If you see our country, people use plants for medicinal purpose for very small elements like sore throat and tonsillitis to a very severe forms like liver problems as well as bronchial asthma and kidney alterations, kidney ailments. The common reason for using plants as a medicinal for the medicinal purpose is one of the belief on the folklore herbal medicines. They have the cultural ancestry that they have been handed over from their elders, and then they have a good belief on that. The other problem is because of the topographic variation, we have limited resources, limited health facilities available, so they don't have any alternative choices, and sometimes the money also takes its bite. So if we talk about the poisonous use of plant in Nepal, it's usually to occurs with the misuse of the medicinal plants. So maybe the person have a half knowledge what which plant has to be used. They have heard their ancestors being using something, and then they're just jumping on that. The other part would be ignorance. So they know which plant has to be used, but they don't know which part of the plant. So it's the seed, or it's the flower, or it's the leaf, or it's the what part they have to use. They are not sure about that. And sometimes it can be accidental. They want to use something, and instead of that, they could not identify it, and they used another plant. Other than that, at occasions we can find some intentional poisoning. So there are episodes of people attempting suicide, homicide, or even abortion using plants. And sometimes it's not human, but people have been using poisonous plants for the fishing. They throw this plants in the pond, and then all the fish die, and then just collect the fishes. So when we are using these plants and in the humans, it can have topical symptoms like skin itching and inflammation in the eye, as well as it can also involve several organ systems like the CVS, CNS, or the GI tract. So if we talk about the burden of plant toxicity in Nepal, so we don't have a clear hospital data on this, but however, if we just Google it, we can use Google Scholar, we can use PubMed, anything, we can come across multiple case reports. So these case reports do show that plant toxicity is a very common problem. And based on these case reports, if we try to compile it, so what do we find is the common poisoning, plants implicated in human poisoning or toxicity in Nepal would be mushroom, amanita, the acotinum, the common name for that would be nirmasi, then the delphinium, it's also known as mahakoti, nerium, or the oleander, the common name for that would be karabir, the Strychnus nux vomica, the common name for that would be kuchila. Then our national flower, rhododendron, the flowers are quite poisonous, lari grass. And then we have the datura, that is also very commonly abused in Nepal. If we talk about the calls that have been received by PIC, Poison Information Center Nepal, we have till date received 6 cases of plant poisoning. Of these, 3 of them were due to the dhatura or the bhang. And then we have one case for the nugget seeds, that is the jaifal. Then we had one case for the jaringo or the pokeweed. And then we had one for the fiddlehead fern or the neuro. This is commonly a staple food in our culture. So luckily, all the patients they were observed in the local hospitals, and then they were discharged in 4 to 5 days of time. All were surviving without any complications. So if we talk about the management, how do we manage these plant poison cases? So the overall management framework would be the same. Initially, you want to start with the resuscitation, the ABCDA, airway, breathing, circulation, and you want to assess the toxidrome. What are the symptoms that the patients are presenting with? Which type of poisoning is the patient? Is the drug pointing towards? Then the other one would be risk assessment. You want to identify the agent, you want to identify the active compound, you want to identify the amount, what amount was taken, the present clinical morbidities, what are the complaints, what are symptoms with which the patient has presented, what are the comorbidities, the liver function, the kidney function, the GI tract. So that can complicate the treatment. And you want to also understand the prognosis. So what do we expect? What can happen in 6 hours? What can happen in 8 hours? So that you can decide where do you want to dispose the patient. Other than that, the mainstay would be supportive care and monitoring. So you want to monitor the patient. You want to provide all the supportive care available. You might need to send some investigations. Decontamination in resource poor setting, like in our country, we might want to decontaminate the patient if the patient presents early within 1 hour. But if it's very late, still it's a risk versus benefit that you want to rule out, that you want to evaluate, and then you can decide on its own. Enhanced elimination is not a very common practice in plant poisoning. Antidotes, there are some antidotes that you want to go for. And then the last one with the disposition, you want to refer the patient, you want to keep the patient in emergency observation, or you want to send the patient in the ICU. That we have to do. Of these all steps, the most critical step, in my opinion, for the management of plant poisoning would be risk assessment. And these are the 5 points that we want to really see. So if you want to see the agent, so the first thing is, even if we cannot identify the exact toxin that we are dealing with, we can try to identify which organ system is the toxin is the most the prominent symptom is. So maybe the person has taken some digitalis plant that would come up with the cardiovascular toxins. Maybe the person has taken some datura plant that can come up with the anticholinergic toxins. So that will help us narrow down which toxin are we dealing with. Other than that, we want to go for risk assessment. So how do we do that? So once we know the agent that the patient has taken, then what can we expect the patient to develop? So for that, the case reports that we have been discussing, that we had discussed earlier, we can go through them. There's plenty of them, and sometimes even databases like the Talkspace, the Up to Date, the Medscape, they also have some information that can also be referred to. And last but not the least, we have the Poison Information Center. You can call us and we'll be happy to help whenever possible. So talking about the common poisonings in Nepal, so mushroom poisoning, it's a very important public health concern in our country. It can present very acutely within 6 hours of ingestion and can also present in a delayed with a delayed presentation of more than 6 hours. Symptoms, it can involve multiple organ system like GI tract, CNS, can present with cholinergic symptoms, and can also have disulfiram-like reactions. So in this slide, I have shown some of the common examples of mushroom poisoning. Broadly speaking, we have three types of mushroom poisoning. The muscarinic type, the early ones in this, you want to go for the atropine. That's very helpful. The hallucinogenic type, it's mainly to the Amanita muscaria and psilocybe-like species. In this one, the you do not want to use atropine in this case because the patient will already be having the hallucinogenic symptoms are not due to the excess of muscarinic activity. And the last one, the phalandoin type, its presence very late. It's due to the modification of the RNA function. So in this again, you have to go for the symptomatic management. Commonly, for the management, if the patient is having excessive vomiting, you might want to go for antiemetics like ondansetron. Here, you do not want to go for the first antiemetic antihistamine antiemetic like promethazine or metoclopramide because it may worsen the hypertension. If a person is experiencing orthostatic hypertension or shock, you just want to position the patient with a leg raised position. You might want to go for some crystalloids that will you want to fill the tank before trying to pump the blood. And then you want to, if it is not sufficient, then you want to start continuous infusion of norepinephrine. If the person has some skin features like skin flushing as well as the pruritus, then we might want to go for older antihistamines like diphenhydramine. The CNS is involved in terms of agitation, delirium, or hallucination. We might want to go for benzos like midazolam. The dose would be 0.05 milligram per kg, or we might want to go for lorazepam. The same lorazepam can also be used for the seizures. The dose will be same 0.05 to 0.1 milligram per kg body weight. And yes, if there's an cholinergic excess, we want to go for atropine. If the patient is presenting late, the liver is already damaged, it has a fulminant hepatic or multi-system organ failure. In that scenario, we want to verify the condition of the hypoglycemia. Blood sugar should be monitored. Then, if the person is having high levels of ammonia, you want to go for lactulose. You want to go for vitamin K to counteract the complications of the hyperammonemia. Then, one thing that we can try is we can limit the uptake of amatoxin in the liver cells or different organ system cells. So for this, the recommended drug is silibinin, but it's very rare to be available in at least in Nepal. So in an alternative to silibinin, we can go for high dose penicillin G. The dose would be something around 40 million units per day. That would be maximum dose. And if a patient is allergic to penicillin G, we might want to go for ceftazidime or cephalosporin. Other than that, antioxidant therapy can be tried to save the liver. For this, we can go for the N-acetylcysteine, our favorite. That is also commonly used for the paracetamol poisoning also. The initial dose, the protocol will be almost same. We want to start with the 150 milligram per kg IV for over 60 minutes initially. Then you want to slow down to 50 milligram per kg over 4 hours. And then you want to continue as a 100 milligram per kg over 16 hours. After this whole course is complete, you want to repeat the liver function test. And if it's still deranged, then in that scenario, we want to repeat the 100 mg per kg IV over 16 hours. The other poisoning that I would like to take today would be the Dhatura poisoning. It's a very common topic of poison in our country. So in a summary, what we can say is the Dhatura poisoning patients, they come up with the anticholinergic syndromes. So they will present with flushing, dilated pupils, blurred vision, dry mouth and tongue, hot dry skin, fever, decreased gastric motility, as well as urinary retention. Initially, they may present with bradycardia, but eventually they will land up with the tachycardia and hypertension. They can have GI symptoms like nausea and vomiting. They can have tachypnea, and they can also have CNS involvement in terms of ataxia, delirium, agitation, aggression, hallucinations, speech disorders, convulsions, myoclonus, hypertonia, and hyperpyrexia. Management, the primary research would be the same: airway, breathing, circulation, assessing the toxidrome. Then for the risk assessment, here what I would like to emphasize is one thing that we want to rule out is whether the person has ingested the datura seeds or it's just a topical application, the topical exposure. Because if it's ingestion, we'll have to manage it systemically. We'll have to be aggressive with the management. If it's topical, we can just try to decontaminate the affected part and we can just observe the patient to see if there's any systemic involvement or not. So monitoring and supervision, you want to check for the pupil size. Initially, it will be mydriatic, dilated mydriatic pupil, not reactive to light later on. As the drug gets eliminated from the body, the pupil will start reacting to the light, uh, will start to become smaller. Myotics can be seen. Then the person can develop hyperreflexia. So for that, we want to monitor the ankle clonus. The person can land up with the metabolic acidosis. So if it is available, arterial blood gas analysis or venous blood gas can be done. Sometimes the patient is very much agitated, and when we palpate the bladder, we see the bladder is really tight and it's distended. So the person is experiencing urinary tension, and we can just catheterize the patient. The urine will be passed, and the agitation can come down. So this is a commonly missed out during the management of the Datura poisoning cases. Rhabdomyolysis, you have to monitoring the creatine kinase, and if it's raised or if the urine output is not maintained, you have to go for crystalloids. CNS is involved in terms of agitation, delirium, psychosis. We want to go for benzodiazepines. Again, same thing. Midazolam or lorazepam can be used, and if it's not sufficient, we might want to go for diazepam. If the person temperature goes really high, the person experiences hypothermia, we can go for physical cooling, just like switching on the fans, using the cool tepid water to mop up the body, to use the ice packs on the groin or the axilla area, or we can go for the uh, more in the literature we have we have like internal cooling methods like using cold water for the gastric lavage or the catheterization. The urinary irrigation uh, documented, but it's not a very common practice. If nothing is working, we can also go for the intravenous dantrolene. Decontamination, if the patient presents early, it's a very good thing that we do, at least in our setup. We can go for gastric decontamination. And even if a person comes and there's no symptom at all, at least it's recommended we keep the patient under observation for 6 hours after ingestion. And at the end of 6 hours, if there's no symptom, we can discharge the patient, send the patient home. If there's any symptomatic symptoms present, we have to perform the following test and manage the patient accordingly. So the last poison, the plant poison that I would like to take today would be the aconite or the nirmasi, the common name for this. So it's a very beautiful blue flower, purple flower present in the, but it's very toxic as well. So the earlier symptoms would be non-specific like GI upset, headache, paresthesia, muscle weakness, numbness of mouth, lips, and limbs. Then the person can present with dizziness, sweating, confusion, and tachypnea, as well as hypotension. The one thing that we want to check here would be the cardiovascular toxicity. Normally, if a person has consumed some flowers or the stem or the other parts of the plant, the person will land up with tachyarrhythmia, which is a very common presentation. But if the person has taken some roots or unprocessed roots, in that scenario, the person can land up with the bradyarrhythmia. So we can. This is a use. It's a very rare presentation, but it is documented. Other than that, severe cases, the patient can have the CNS involved, convulsions, delirium, coma, can also experience respiratory depression, and uncommonly, person has been there have been cases presenting with the acidosis, hyperglycemia, hypokalemia, and waist creatine kinase. Management, hypertension, the old golden rule: fill the tank, give him lots and lots of crystalloids. That will suffice in most of the instances. Metabolic acidosis, once you hydrate the patient, once you correct the hypoxia, the acidosis should go away. If it's not, we can go for sodium bicarbonate. But while we are doing this, we also have to be careful about the potassium levels because sodium bicarbonate is known to cause hypokalemia. Arrhythmias, patient is landing up with cardiac arrest. We might want to go for sodium bicarbonate. Patient is landing up with the bradyarrhythmias. We want to go for atropine. Ventricular tachycardia, fibrillation, because this aconite, the active drug, is known to prolong the opening of sodium channels. So we want to use class 1A sodium channels like flecainide, or if we have, or we want to go for the broad spectrum anti arrhythmic drugs like amiodarone. Now, if available, ECMO can be tried, but again, the availability of ECMO is a big issue in our country. Gastric decontamination, again, within 1 hour, it's a very good thing to do. It will help to improve the prognosis of the patient. And at least the patient should be observed for 4 hours after ingestion. If after at the end of the 4 hours, this patient has no symptoms or it has normal ECG, in that scenario, we can discharge the patient to come as required and request the patient to return as required. Otherwise, they should be safe. It should not be a big issue. So to come up with this presentation, there were two people who have really helped me throughout the process, Dr. Rakesh Kimiri and Dr. Rishika Karki. They have been helping me from the very beginning. And a special thanks to my mentor, Dr. Sangaratna Vajracharya sir. He has been guiding me since 2015 and is going and hopefully he will guide me throughout my career. So these are some of the references that we went through to prepare this presentation. These are only some. I have not included all of them. So if there's any queries, maybe we would like to go through these references. So with this short presentation, if there's any queries, I would like to take them.
Thank you so much, Dr. Pravin. That was really good overview. You know, we definitely are a country that has tons of plants, and you know, that's just a kind of a little yeah, Jim loves mushrooms, so I don't know if you wanted to add anything about the plants you heard. But yeah, we've been, datura is something that grows everywhere in our, and then rhododendron, of course, we get the mad honey poisoning because of that as well. But there's a lot of if you guys have questions, maybe we can take one or two more questions. Unfortunately, we're over time. There is a question here. Are there any toxic or fatal dose for datura poisoning?
There is a toxic dose for the datura poisoning. I don't have the exact number right now, but I'll just get to you if it's okay.
Yeah, dhatura, I have personally taken some dhatura in the past accidentally, and and it can have some bad psychedelic effect. But yeah, I don't know the exact dose either, but that's something we can probably get back to you on. But just
We'll
don't
come back
don't
to
eat dhatura. Avoid it at all cost.
If I could give my 2 cents, I mean, I am not aware of a weight-based toxic dose or kind of number of seeds, but and I don't know how many deaths have been reported. My thought would be, though, I mean, those seeds are fairly potent and small. I would have thought at some point there's been someone who consumed enough of the seeds that they actually had not only really bad anti-muscarinic or anticholinergic toxicity, but had seizures, coma, and death. I think you definitely could get to that point.
Yeah.
I loved your talk, Dr. Pravin. That was wonderful. And I love the discussion of mushrooms, and datura, which I think is a beautiful plant. And I have some in my garden here.
That's great. Okay, I think I think that's all. We unfortunately we'll look at all the questions here and then we'll try to compile answers for you guys. Dr. Pravin, if you don't mind unsharing, we're so again, I just want to remind everyone, thank you so much for coming. 450-2011. We're available 24/7, and we have medical toxicologists like Dr. Jim who are 24/7 available to us to help out on our WhatsApp. So we don't not only have the national expertise at our poison center, we have the international expertise, and we're really trying to advance our poisoning care throughout the country, as this is one of the largest burden of morbidity and mortality for our country. So please tell your friends and add this phone number to your phone. Before we go, I would like to invite from our sort of implementation partner in Nepal, TUTH, Clinical Pharmacology Department. We have Dr. Sangaratna Bajracharya here, and maybe invite him to give a little vote of thanks to our speakers today and to close the session. But right before he goes, we'll take a picture, so don't go anywhere.
Okay, thank you, Dr. Rami. So I'm very happy to hear both the presentations. So first presentation, I'd like to thank Dr. Jim Whitledge from Northern New England Poison Center. So it was very interesting and eye-opener. And like he has taught us so nicely with very self-explanatory endoscopic pictures related to caustic poisoning. And I'm very thankful that he has highlighted very important points, like unlike other poisoning, like some of the things which we should be cautious about, like, like not to neutralize and not to use activated charcoal and no NG tubes, and definitely no induction of vomiting, etc., etc. And I was very interestingly listening to the endoscopy, where like you cannot do endoscopy early in the treatment. It may cause further damage, and even like it is like I learned from Dr. Jim that it is very important for doing endoscopy for a Jarger score to see whether circumferential fibrosis is there, and whether we can use steroids. So that was very nice point to me, and like even I was very happy that somebody rightly pointed out when it is ideal to perform the endoscopy for that. And like I was very happy to learn that like it is to be done after 48 hours. So there are very nice points and very like nice phrases he has brought, which is quite catchy and easy to recall for treatment like during this one, like this caustic poisoning licks the esophagus and bites the stomach. So nice it is. And even like he has used his various experiences to treat like some of the poisoning, like common way of poisoning, especially in children, like button batteries ingestion. And very nice to hear that even the readily available substance like honey at home, which can also be utilized for minimizing the toxicity. I thank you, Dr. Jim. I really enjoyed the presentation throughout. And I also like to thank Dr. Pravin Prasad for the comprehensively discussing about so many plant poisons within the short period of time. Very nice bird eye view was presented. And actually this plant poisoning is increasing in number these days. And you have put very nice pictures so that we can even recognize the plants by looking at your pictures. And so nice to hear like comprehensive summary of common poisonings due to various poisonous plant in Nepal. I thank you so much. And similarly, I'd also like to thank Dr. Ramu and the team from Brown University for continuous support and also for coordinating this presentation. And I would also like to thank our friends from Ask Foundation and also the SPICE, that is Specialist in Poison Information, from our Poison Information Center, and our department families from Department of Clinical Pharmacology. And I'd also like to thank all the international and national delegates who are present here. And it's very impressive number that till the end at this evening. So actually, this is the time probably for dinner for most of the people in Nepal. So you are patiently participating till the end. Till now, like 51 members, we were around 60 members earlier. So thank you so much. And I hope for this kind of overwhelming participation even in future. Thank you so much.
Thank you so much. All right, if everyone can open up your camera, we'll take a quick group photo with Dr. Jim and Dr. Pravin here, our speakers and honorable guests. So, and then please, if you have not saved that phone number again, call the Poison Center. We only exist because you call, so you got to call. Right, nice. We're seeing everyone's I'm hungry faces now. This is great. Licks the esophagus, bites the stomach. That's our phrase for today. Okay, is everyone ready for the picture? खै धेरैको त खै यता त खुला छैन त. Please open up your camera. Thank you. Nice. Okay. All right, I'm going to take the first screen. First screen, I think everyone is on. 2016 stress day is not on. Okay, all right. Say cheese in 1, 2, 3, okay? Cheese, 1, 2, 3. Nice. Okay, one more. I hope this is working. Okay, one more in the next screen. All right, I think I got everyone. Okay, just reminder, this is recorded and it will be on our YouTube page. We'll email that out to you afterwards. The CPD form is here on the chat. So if you want credit for this, please fill out that form. And then number 3 thing is we have a vibrant Instagram page, PIC Nepal, where we put education information almost every day and announcement for things like this. So please follow PIC Nepal page on Instagram as well. That being said, we are done for today. Thank you so much, everyone. Bye-bye. Have a good night.
Nice speaking with all of you. Thanks, Ramu. Thanks, everyone. Bye.
Thank you. Bye-bye.
Thank you, Dr. Ammo.
Thank you. Please fill out that form.
Yeah.
Dr. Rakesh, भात खानुभयो?
अब खाने
मजाले आरामले भोक नलागे जस्तो गरेर बस्नु भएको छ, त्यही भएर खाइसक्नु हो क्या?
म प्रेजेन्टेसन सुनेर आइ एम सो ह्याप्पी टु हियर दि स्पिकर्स, त्यही हो।